Hey everybody, welcome back. Another episode of Goodreads. In this one, we're going to talk a little bit about the right bundle branch block and some clinical context. But as a review, the last episode on the right bundle branch blocks, we talked about pathophysiology of the right bundle branch block, why we see what we see on the 12 lead. And as a general reminder, there's three criteria: QRS width greater than 120 milliseconds. We have that RSR prime in V1, sometimes extending down to V2, and a deep S wave out in V6. So looking at the 12 lead, just a reminder, in V1, you get this RSR prime. You have a deep S wave out in V6, QRS greater than 120 milliseconds. Also something else that you can do. This is the cheater method, but if you imagine yourself as starting to drive a vehicle, start on the T wave, and you drove down the T wave to the QRS, and whatever first turn you make determines whether that's a right or left bundle branch block. So this is a cheater method. There are actual 12 lead criteria to define this, but as a shorthand method, if you imagine yourself coming down the hill of the T wave to the QRS complex, the first turn that you make, either right or left, in this case coming down the T wave, you're going to make a right-hand turn. That is a right bundle branch block. So like I said, just a quick method that you can to pick that out really quickly. But moving on, we're going to cover some clinical context for the right bundle branch block. And basically what that means for you as a provider when you come across somebody as a right bundle branch block, what's the next question you need to be asking yourself? And I want to start with two cases. Case number one, 43-year-old with shortness of breath after surgery. Alarm should be going off in your head, right? Anytime that anybody is post-surgery, they're short of breath, we're concerned with venous stasis, so the concern is very high for a pulmonary embolism. Surprisingly, a right bundle branch block is not the most sensitive finding on the 12 lead for a pulmonary embolism. It's actually just your standard run-of-the-mill sinus tachycardia is the most sensitive finding for a pulmonary embolism on the 12 lead ECG. But nonetheless, we do see this RSR prime pattern in V2. We have deep S waves out in V6, QRS complex, greater than 120 milliseconds. And so this is case number one. And I want you guys to keep this one in mind, but we have a right bundle branch block present, some sinus tachycardia, and the concern clinically for a pulmonary embolism. And I want to flip this, and let's go to case number two, 78-year-old with COPD. Same thing, we have this RSR prime pattern in V1. We have a deep S wave out in V6. And the question that you need to ask yourself when you're presented with these two cases and anytime with a right bundle branch block is this an acute process or is this a chronic process? So in the acute process, right, the pulmonary embolism is an acute process that's happened for this 43-year-old that's post-surgery as opposed to the 78-year-old with chronic COPD and probably has frequent exacerbations, right? And so that's question number one that you need to ask. Is this an acute process or a chronic process? And let's talk a little bit about the pathophysiology that's involved with both of these. So anytime that we are presented with a right bundle branch block, it is usually as a result of increased pulmonary pressures. So that's what's happening out here in the lungs. We have an increase in pulmonary pressures. So let's take the acute process. In the acute process, like we did with our example, a pulmonary embolism, we have an embolism that forms maybe here, or a large embolism, a saddle embolism that forms here. And what we get is this very, very high pressure in the right ventricle. And this right ventricle is a very thin-walled ventricle, and it's not used to accommodating very significant pressures in the pulmonary system. So anytime that the right ventricle is overcome by a significant amount of pressure, i.e. trying to get blood around these clots, what's going to end up happening is the right ventricle is actually going to distend. It's going to engorge. It's going to get very large. And what actually ends up happening is that pressure gets put on the right ventricular walls, especially here on the septum, and it's actually going to push the septum into the left ventricle. And by doing so, it's actually going to obscure this little tract right here, so blood can no longer exit the left ventricle. And this is why we see hypotension in really, really severe pulmonary embolism patients. But the right ventricle, anytime that there is an acute process, will begin to distend and engorge, and that will mess with the actual fibers, the conduction fibers running down that right bundle. It's typically why we see the result of the right bundle branch block, is because with that right ventricle is becoming slowly, very distended, very engorged, and there's actually remodeling of the right ventricle that occurs. And so that's the acute process. Now let's back all of this up and let's say that we're dealing with a chronic process. Let's say that there's increase in pulmonary pressure, same thing, but it's chronic. It's due to a COPD issue, and this is years and years and years of ongoing COPD issues. What's going to actually end up happening is you're going to get hypertrophy. So in an acute process, you're going to get distension and remodeling or altering of the shape of the right ventricle to become engorged. As opposed to the chronic process, you're going to get this hypertrophy, meaning that there's going to be recruitment and enlargement of this actual muscle mass here on the right ventricle. This, as a result, will once again alter that actual fiber of the right bundle branch block coming down the septum here, and that will result in the right bundle branch block. So it's very different for the pathophysiology, and that's kind of the basis of the understanding. The acute process, you get distension, remodeling, and in the chronic process, you actually get hypertrophy of the right ventricle. So in terms of what this means clinically, this is the question you need to be asking yourself, acute versus chronic. And the general statement, which we'll cover in the next talk, is that any ST elevation in a right bundle branch block is concerning. So if you're curious about the next talk, we're going to go over what to look for in MI.